To all who are new here, my name is Dr. Michelle Henney, and I'd like to welcome you to Releve Sports Medicine's Virtual Journal Club. For additional webinar educational opportunities, you can visit our website and register directly for the webinar or sign up for the email list to be notified of upcoming webinars. We are continuing to update our schedule, so check back often. For all athletic trainers who are intending to get live CEUs from the BOC, you will receive an email 1 hour after the webinar concludes, which includes a link to the combined quiz evaluation and assessment. You will have up to 72 hours to complete the quiz and the evaluation. This email will come from customercare@gotowebinar.com. Please ensure that this is done to receive your statement of credit. If you don't receive the follow-up email or you have any other concerns, then contact us via our email at journalclub@relevesportsmedicine.com. Once the statement of credit is available for download from our website, you will receive an email notification. If you have any questions during the webinar, please submit the question and we will review questions at the conclusion of the presentation. If you cannot see the PowerPoint slides and you're accessing the webinar from your mobile phone, swipe the screen to the left or to the right and the slides will become visible. The recording will be available for review from our website tomorrow. Our speaker this evening is Dr. Alex Herzlin, who is a physical therapist. He received his bachelor's in exercise science at the University of Florida. During that time, he worked as a personal trainer and eventually as the director of personal training development at the University of Florida until 2008. He completed his Doctor of Physical Therapy program at the University of Miami in 2011. He completed a sports residency afterwards to become a board-certified sports certified specialist, as well as completing the Orthopedic Certified Specialist certification. He is currently the sole physical therapist for the LPGA Symetra Tour, and he co-treats on the LPGA Tour. And he will be speaking tonight. So I'll go ahead and give you the floor.
All right. Well, welcome. Just a quick comment. This first slide, we'll see it again on slide 8. I put it on right now. If anyone's very visual like me, these are the slings, the lines we'll be going over. If some of you guys want to do a quick Google search and maybe open a separate tab on your computer, it will not be hard to find this picture to then have a kind of a side comparison as we go. So today we will be going over a sling-based approach to golf rehab and performance. As Dr. Henney mentioned, I spend about half my year traveling with the Pro Sports Tour. The Symetra Tour is purely women's. We don't switch over, and LPGA as well. When I'm not on tour with them, then I actually do not do a ton of clinic work. Since my background is strength conditioning, I do a lot of program design for athletes. So I basically manage the year-long programs of athletes, not just golfers. And then I also just serve as a consultant for different strength coaches and the like. All right, so get this out of the way real quick. I have no relevant financial relationships regarding this, and I will not discuss products, although I will cite Anatomy Trains as a book that is kind of the gold standard of sling talk. All right, if you guys want to take a deeper dive into this, I strongly recommend it. If you guys want this as more as a maybe more of a general sense in your practice, then to be completely honest, you can do a Google search and you'll find tons of trainers and strength coaches and PTs that have written great articles on it from their own experiences and research. So we want to be able to understand myofascial slings, and this talk again will be really how they contribute to the golf athlete. We want to be able to apply these slings not just in injury, but also in a golf performance program. In my opinion, they are one and the same, right? And then using really more of a regional interdependence framework for early and mid-stage rehab. So this is the book. I just, again, I don't mean to promote a product, but I really feel like this is where my base comes from. And so I would be a little remiss if I didn't give them tons of credit here. The book's been around for forever. They have courses and everything. Other people have made other books as well, so this is definitely not the only source you can find. Okay, so golf is hard. If you don't have a strong background in golf, just a quick overview. Looking, the picture on the far left is a backswing. The third picture in we'll just call contact, and then the picture on the right is follow through. So again, if you don't have a golf background, I may reference parts of the golf swing, backswing, ball contact, and follow through if you also want to have a picture up. Okay. Okay, so when we have injuries, right, the first question is why did it happen? You know, we have a situation like this, we know how it happened. That's super unfortunate for the Alabama guy, but fortunate from a rehab perspective because there are no questions about what happened, what went wrong, etc. But obviously, a lot of our athletes come in and they just complain about a body part, but we don't know how it happened. You know, I'm fortunate to spend half the year with these same athletes, so I know their bodies, I know their swing, and so a lot of times I can get an idea of what happened. But a lot of other clinicians, you know, and sometimes I have a new player, we don't know their bodies. We have a blank slate, and they just say, "Am I?" You know, when I go into my backswing, I feel a catch. You know, that's what I get still. All right, and so our initial goal is always to find out why something happened, not just the body part hurt. And then once we get it from there, we then have to decide what to do about it, right? If we go back to this picture, you know, I think a lot of us know, and I still think this, and definitely used to think more, when I get someone that's super acute with a traumatic injury, a lot of times one of my initial thoughts is, well, what can I do? Like, you know, they're too acute, they're too hurt, it's too extreme. So what am I going to do during these early stage? This early stage, it's especially if the athlete is expecting you to work on them for 20, 30, 45 minutes. All right. So, you know, so that there's the question of just isometrics, basically. Can they not do anything else? Right. And then from there, we would go into programming goals, right? What are our goals for this program? And so when we look at early stage rehab, like, do we stay local? You know, and how long do we stay local? We initially go to global, and then whenever we have athletes, we have to factor in the mental component, right? A lot of us got to this position because we were athletes, right, when we were younger, and then we got hurt. I know that's how I ended up in physical therapy. I was in PT when I was like 8 years old. And so I'm sure you guys can remember that when you were athletes and you got hurt, you know, it tore you apart mentally as much as physically, right? Because you have this immediate thought of, I can't do anything. I'm basically useless for however many weeks we were told that we couldn't participate, right? And then once we get to later stage rehabs, we have the huge question of programming, right? And so if you don't have a strong background in programming as a strength coach or a trainer or something like that, I think it's a little bit like, where do I start? Do I, you know, so if you don't, those programs on the left, like a push-pull routine, so you do all your pushing exercises in one workout and then all your pulling exercises in the other. A ton of athletes do whole body workouts, right? Going back down further, if you're a bodybuilder, you're going to isolate. The fourth is a kind of a joke, but not really, because a little bit of pet peeve of mine is, do you make exercises that just look like you're golfing? In the golf world, in the strength and conditioning aspect, we still have maybe some confusion about the carryover of exercises that look very golf specific to one of the most specific movements in the sports world, being the golf swing. And then how do we throw, core into that? Obviously, the catchphrase at core, like, everyone's like, you got to strengthen your core, you got to strengthen your core, but when do we do it? Okay, so this is the slide that you guys saw on the first one. And we're going to kind of go through all these. The one thing I want you to notice is the ones that I bolded and put in red. I did that. We're going to save those till the end because we would call those basically the most physically driven lines in the golf swing. and probably the ones that you are going to spend more time prescribing exercises for. Okay, the functional lines is kind of self-explanatory with in the name with function, and the lateral line though, if you are fairly new to golf, understand that there's a very strong lateral component. All right, so basically we're going to completely weight onto the back leg. On a right-hand golfer, that would be the right leg, and then as you swing, you are going to completely shift onto the left leg. So you are doing a weight shift from one to side, which puts a force into the frontal plane. Okay, so superficial backlines. In all these slides, what we have done is there are two lists, a left and a right. The left is soft tissue, the right is bony prominences. We are going to talk more about the left just because that's what we can affect really directly. And then our goal is to basically indirectly affect things on the right. That being said, I do think that this first slide has probably the most interesting bony prominences of possibly all our slides due to the injuries that we can see. All right. So when we talk a competitive golfer, what we're going to see is a hypertrophied and strong right erector set. And then we're also going to see a right ankle that's stuck in basically plantar flexion. If you can imagine, they're always pushing off their right ankle. And so we're often going to have an increased plantar flexion, decreased dorsiflexion on the right. And so if you look at it in here, if we have an erector set that is really strong and tight, and then we have this set that's strong and tight, and then we look between them and outside of them of what can be stressed. And so the number one thing is we look at basically a sacrotuberous ligament that can be stressed a lot because it's getting pulled on both sides. It's no surprise due to kind of the stresses of the sport and then body shape that we see a large number of SI issues in women's golf. The other issue we can see is a plantar surface of the foot issue. Maybe because of this situation, or maybe because of how they roll over their foot, we will see a much higher incidence of right hallux valgus in a competitive golfer. The reason that I think that this slide is a little bit more interesting as far as bony prominences is because of the very obvious situation of a calcaneus and an ischial tuberosity and sacrum. The reason being that obviously a golfer walks a lot. If you guys are not familiar with competitive golf, there are no carts in competitive golf unless every once in a while there is two holes very far apart. When they make the turn, they will be allowed to, there will be a shuttle from one to the other. But outside of that, they're walking. If we get a calcaneus issue in the middle of a season of professional golf, we are in a world of trouble. And so if we have a tight gastroc Achilles, then we have stress put on the calcaneus, all right? And so what we always want is stresses to be basically even and symmetrical. And that's how we can see if Achilles and gastroc are super tight, then we have stress at the plantar fascia and stress at the calcaneus. Two things that we really can't afford there. The other thing, to a little bit of a lesser extent, is an ischial tuberosity. I include that in my kind of list of important things just because of how stubborn it can be. The other issue with any really sort of pro athlete is the travel. There's a lot of sitting in uncomfortable planes. If we have, due to tightness, the gastrocs pulling the hamstrings down, the hamstrings are pulling on the ischial tube down, and we start getting basically a bone stress on the ischial tuberosity, you're going to then have an athlete that reports after what should be a rest day, but they sat in a plane or sat in a car for hours and hours, and that's suddenly going to be their worst day of the week. All right. And so in this talk about how everything is connected, this one's a little easy because it is obvious that this Achilles and gastroc being short can very much affect what is right below it and above it. Okay, so when we go to the superficial front line, this will be probably the one that we stress the least on here. The truth is, in the golf swing, it is probably stressed the least. Not the same in very much other sports, but in golf we are very much posteriorly driven. All right. The couple things that I want to touch on here is, to start, is we look at abs, right? When I go to the LA Fitness around the corner from my house, everyone's doing crunches, everybody. When we get into the golf strength conditioning world, suddenly that's taboo. And then sometimes we maybe kind of flip to the opposite side of not doing enough anteriorly based things. If you look at the golf swing, on the finish of a golf swing, you're going to be in an anteriorly stretched position, right? Among other things, your rectus abdominis is contracting eccentrically and basically needs to slow you down, or you're going to end in a back extended and rotated position just by basically mashing into stuff. And so when we think about rectus abdominis in golf, we really need to be thinking of it basically as an eccentric controller of the ribs and pelvis. Right? The other thing we can start looking at here is something like the SCM there. You know, with golf, we obviously have a ton of cervical rotation, and so when a right-handed golfer finishes, they're going to be in full right cervical rotation. So right cervical rotation is basically a shortened left SCM, and so it's just something to start thinking about, because we're going to see SCM mentioned again in other lines. And so look now that if your rectus is stretched and your right SCM is stretched, it's going to allow other things to shorten, right? Like quads, which a lot of people are very dominant, especially golfers, since they train so much. And that could stop these couple from ever kind of returning back to normal and result in basically a lengthened and then weaker area of a few different muscles. Okay, so spiral line is a big one. Okay, this one, to be completely honest with, is one of the ones that I hope you guys are looking at a different picture, because it then starts crossing the body. All right, I know me that I have trouble picturing the spiral line now. I have references on my wall a lot of times when I am treating in a clinic, but obviously important because of the rotational control aspect. So in the next slide, we're going to see this, but one of the most interesting things with the spiral line, in my opinion, for golf is the relationship of the rhomboids and serratus. You can also continue that into the contralateral splenius capitis. And so the reason that's interesting to me is, especially on the left side, your shoulder blade is going to go through a big range of motion. So think in your backswing, your left arm will go across your body. Again, right hand, everything will be right-handed golfer. Will be across your body, and so your shoulder blade will go with that, right? Ideally, and then follow through. You are now in a horizontal abducted position, and so your shoulder blade is adducted in, ideally. You also need to keep your shoulder blade snug and controlled, which we all know that your serratus is very heavily involved in. And so the reason I say this is because once we start looking at these relationships in the lens of that everything needs to be like equal in its tension, right? It might change how we prescribe exercise. So I'm sure everyone's heard a million times to squeeze your shoulder blades together, right? And so just quickly on that, so obviously when we, let's see, do scapular adduction, we have our rhomboids and our mid-traps essentially, right? But the huge difference between those would be your rhomboids would be then a downward rotator of your scapula, your mid-traps would be an upward rotator of your scapula. Along those same lines is your serratus, which is also an upward rotator of your scapula. So everyone has their ideal exercises to give. And if you look at it as purely, I need some shoulder blade retraction, then you might not look at it as, do I need to stress it in a downwardly rotated spot or an upwardly rotated spot, or do I not care at all? But if we then look at it more as far as the relationship between rhomboids and serratus, and in that, what I mean is that we don't want our rhomboids to be super overly active, or then they might win, right? That tug of war with the serratus, that we want to be an equal relationship. So if our rhomboids are too on because we're stressing shoulder blades down and back, down and back, down and back, do we then inadvertently decrease the ability of the serratus to do its job because of how closely they're related? You could take this one step further again with looking at the contralateral splenius capitis, because we're also going to have a compressed right upper cervical region. So on the next slide, there will be a picture of that I think shows it even better. The other thing that we're going to look at here is the TFL. We stress the TFL, I think, because for a couple reasons. One, a golfer is often going to be unequal in their range of motion due to putting so much internal rotation through their lead leg, left leg. So in that sense, your TFL, your internal rotator, might be in a shortened position. Most muscles are kind of ideal strength in a quote unquote their optimal position, which is neither shortened versus lengthened. But if we're comparing a shortened muscle versus a lengthened muscle, usually a shortened muscle is going to get stronger relative to the lengthened counterpart. On the lead leg, we're going to look at it here. Your TFL is short. Your sacrotuberous ligament on the lead leg is often short, and your peroneals are super strong. All right. If we look then, the things that stick out to me are, we have a biceps femoris, which is kind of sandwiched between sacrotuberous and peroneals, and then we have a tib anterior, which is sandwiched between peroneals and TFL. I think then it comes as no surprise that I see a number of biceps femoris injuries on the lead leg and tib anterior injuries on the lead leg, although the swing itself would not necessarily make you assume that I would see that amount of prevalence. And so the question is, am I just wrong in the function, which, you know, I'm wrong half the time, so distinct possibility, or are these links in this chain being stressed because they are then being lengthened, right, through fascia, because of the shortened links above and below both of them? I think, especially maybe just me, as I was coming up in the clinic as a clinician, I did not do a ton of work to lengthen a TFL, both manually and exercise based, right? You're always working on glutes, you're always strengthening glutes, but TFL, partly because it's hard, you know, I think that's the easiest way to have your thumbs exhausted, is to do too much TFL work, right? Luckily now I can just poke needles in people. And then same with tib anterior, you know, coming up, I did so much gastroc work and soleus work that I wouldn't give a tib anterior that much love, or that much strengthening, right? The only people I really viewed as tib anterior strengthening were runners, right, to control that. But now I would prescribe basically any of my golfers to do some tib anterior work, just to keep basically that honesty of the peroneus longus, by making sure it can't just bully the tib anterior. Okay, so this is that picture I was talking about, and this is why, if we are looking at it from a myofascial slings lens here, your rhomboids and your serratus anterior are practically one muscle. In my head, that's not the exact same. I view it as a seesaw. I view them as they are pulling so much, right, directly in line with each other, that you cannot make a rhomboid super strong, like increase its tone whatever, and or shortened, and it not, pull on your serratus anterior. And again, in most cases, if your rhomboid is shortened, right, and so what we would see here in a shortened rhomboid is downward rotation. So we'd see the scapula more at this angle, right? So this would be this way, downward rotator. We cannot have that without your serratus being lengthened, at least in part of its fibers, right? Same with the distance that we measured, lateral border or medial border of the scapula to spinous processes. In an average adult, we're thinking about 3 inches. If we cut that number to 2 inches, we simply cannot do that without then pulling on the serratus and making it lengthen, right? If the serratus is not lengthened, it's because it's yanking on your ribs, and then we have a whole different issue. Okay, so the next up are going to be the front lines, or the arm lines, sorry. And so what they are going to be is they're going to be split up into 4 arm lines, a deep and a superficial of both the front, and then a deep and superficial of the back. You know, when we talk about athletes in general, but I think especially golfers, you're going to have people on different sides of the fence with how much they treat distally. All right, and so what I mean by that is it would not be hard to Google search treatment of tennis elbow, and I did intend that, which we'll touch on, because in golf I treat tennis elbow. But anyway, it would not be difficult to do a Google search of treatment of tennis elbow, and there's always going to be, I hate to admit, it's always going to be some PT bragging about how smart he is because he treats the shoulder, right, the upper quarter, because he knows something that no one else knows. And then you're going to have other people that are just making someone have Popeye arms, right? They think if your wrist flexors or extenders are hurt, if we make them the strongest in the history of the world, they won't get any more injury. That there might be some truth to that, and you know, strength prevents injury, right? And there's truth to the other area. You know, in research it shows if we just treat someone's symptoms at their elbow versus if we don't touch their elbow and just treat the shoulder, a lot of the research shows you get better results from the shoulder. And so I don't really have a strong opinion here either way, other than I think that you need to combine them, right? I don't think we can have an elbow without a shoulder without an elbow. And that's one of the things that I love about an approach like this, is it shows that connection, right? And so the good thing is then I'm treating multiple things, but I'm not treating everything. So I'm not treating someone's entire upper quarter, right, when I go basically fingertip the shoulder, right? So when we look at the deep front line, the number one thing that might be a little bit confusing if you're not huge into golf would be a pec minor situation. The reason this is so huge is because someone's setup will shorten their pec minor on their lead arm. All right, when someone sets up to a ball, which on a practice / playing day they're going to do hundreds of times because they hit a ton of golf balls. When they set up, they are going to bring, sorry guys, I can't see myself in this camera, so I hope you can see me. They're going to have this shoulder here, and they're definitely going to shorten this pec minor. If you put any competitive golfer on a treatment table on their back, you're going to see one shoulder higher off the table due to shortened anterior musculature and fascia. All right. So when we have a pec minor dysfunction, I think many people would immediately draw a line to the biceps, largely because biceps tendon. Okay. If you have any sort of postural fault, you are going to have a proximal biceps tendon risk, right? I think that's probably not new to many people. This really just, to me, shows the parallel here. And so if we look at this cool skeleton, we have a pec minor here, and how closely the fascia would then go into biceps. I would take this one step further, and this is kind of more in the lines of how this guides my treatment. And so I immediately see thenar muscles. I think thenar muscles basically give you a big kind of bang for your buck, big control due to how strongly they're innervated. And then obviously, if you have a hand issue in golf, you have a big issue. So what we're going to have is when we have this player, and this is kind of what I was meaning as far as how much can we treat. When I have a competitive golfer, we're going to work pec minor. We are. But obviously there comes to a point where we can't work anymore. It would just, your return stops, and eventually you just start getting sore from all the manual. It's a hard thing to very specifically target during exercise. So then we're stuck with where are we? And in my eyes, where we are is then we make everything else on that chain healthy and happy. And so it cannot be losing the tug of war fascia due to the tight pec minor. And so that is why we are going to, and a lot of times, to be completely honest, this is something that I would have my players do themselves, but we're going to take care of a lead hand thenar group before we have an issue. Okay, if you think about the golf swing, a lot of times we think that lead hand, the thenar group shouldn't really be that stressed, and so a lot of people would not pay attention to it unless we're more looking at a relationship of this, of working the thenars to make the biceps and the pec super happy. The other things that we can see here in that same breath is we have a few things on the right side, on the right list, that we really don't want to get unhappy. Obviously the scaphoid, we don't want any carpal issue, but especially not the scaphoid. And then the other thing is the third, fourth, and fifth ribs. If anyone's treated an anterior displaced upper rib, it's a horribly uncomfortable situation. In competitive golf, we do have them. Many female golfers, they don't have a lot of soft tissue up top. If you palpate anterior ribs, you're going to feel protruded ones, and it is likely at least partially due to how much the pec minor is pulling on them on a fairly consistent basis. And if it ever gets too far protruded that their body realizes it and shuts them down, you have a big situation in that there's a risk then of a player simply not being able to play. So from the deep arm line, then we go to the superficial front arm line. And so this line, we will not spend a lot of time here. And actually, let me backtrack real quick into something I mentioned, just in case. I apologize, guys, but I can't see if there's any questions. And I was talking to Dr. Henny, and I always get worried that I'm losing people, right? And so what I mentioned before about the golfer's elbow and the tennis elbow, right? Golfer's elbow and tennis elbow, this is very obvious to some people, not to others, is kind of named due to the recreational athlete. Keep that in mind. So a tennis elbow extensor group, a golfer's elbow medial group at the elbow. A golfer's elbow most likely happens because someone chunks it all the time. When they try to hit the ball, they hit the ground and the earth doesn't move too much, and they stress it like that. By the time you get to competitive professional golf, they are very rarely chunking the ground. Every once in a while, you will have a player try to hit out of rough, and there's a tree root right near the ball that they may or may not see, and they have to try to hit the ball. They hit the ball, but then their club hits a tree root, which doesn't give. I've had tennis golfer's elbow start due to something like that. But outside of that, the truth is a trail arm on a professional or even probably highly competitive college golfer, we're going to have bony deformities due to basically the carrying angle. We're going to have a valgus, and they're going to have intra-articular issues before they have a golfer's elbow. All right. You'll have some people with flexor group issues. A lot of them will know and admit that they grip very, very hard. Right? So that being said, I don't deal with a ton of flexor group issues, but this slide to me would also demonstrate why when I program from a golfer, they do chest stuff. Because if you do, you know, if you're talking to another strength coach and they ask, why in the world are you doing pec stuff? This is one of the reasons, because of the connection of the pec and their flexor group. So again, while it's not a priority to me, it is something that we address to not have an imbalance. Okay, so deep back arm line here. The big thing I look at when I see here is, so I think a lot of people, when they look at this slide, you know, we have the rotator cuff here. Everyone here treats rotator cuff, right? Tons of people are constantly working on strengthening your external rotators, your infra anteriors, right? Manually, a lot of people work on the external rotators, and they're superficial. It's easy to work on, right? There's always going to be trigger points, and you're squeezing it between that and a big flat bone, you know, so you can make someone squirm easily. Why not do it, right? But if we look down this line and we look at things working all together, I'm sure many people here do, but tons of people never work on the triceps, right? And so if they're working together, I think it raises the question of why are you working rotator cuff and not triceps? And then same with your hypothenars, right? A lot of people that, at least that I see, I think even the ones that work thenars really don't touch, right, the medial palm in the hypothenars. But if we were talking myofascial connections and we want the rotator cuff to be happy, I think we're kind of missing the boat there. If you do get a competitive golfer and you do dig into hypothenars or triceps, you would find a trigger point immediately, because it is stress muscles. And so if we don't work on those and we just have these latent trigger points, because they are often latent in that you don't feel them unless you poke them, even if they're there. And so if we're looking at this theory of interconnectedness and we have, let's say, a tricep that has a trigger point, so it is simply not lengthening how we want, and a hypothenar muscle group that has multiple trigger points and not lengthening how they want, then they're constantly pulling down that chain, and then you might make the leap then that the rotator cuff muscles are constantly getting pulled on. We are then adding that by relaxing the rotator cuff muscles with manual therapy, and we might be doing a little harm there if we're looking at the rotator cuff as an isolated approach. Another just side comment, in golf, relative to a lot of other sports, I really want someone's shoulder internal rotators super strong for two reasons. First, they're going into external rotation on both the backswing and the follow through, and need an eccentric contraction of your internal rotators to stop your arm from flying off. Okay, so if your subscap is not strong when you go from your follow through and initiate your downswing, you're going to hurt your shoulder, because your hips are going to start it with a lot of force. You are in shoulder external rotation on your trail arm at that point, and it better be able to hang on and not just be flown into more external rotation. And then on your follow through on your lead shoulder, we're going to be going into external rotation very forcefully, and our internal rotators better be able to handle that. The other reason that we think internal rotation is, right, our shoulder internal rotators, if we're thinking about it arthrochromatically, are going to cause a posterior glide of the shoulder. In the golf swing, when you're reaching that, especially that lead arm across your body, you're pulling it anteriorly in its socket. If you think about females, often more lax, right? A lot of times we have too much anterior laxity, and a lot of times a humerus that just simply sits in its shoulder socket, especially on the left side. And so we really want the subscap holding its own. All right, and so that goes back to, if we work the posterior rotator cuff, we don't do anything to make the triceps happy. We don't do anything to make the hypothenar muscles happy, and we don't strengthen your internal rotators, your subscap. We're kind of setting the table for this infraspinatus dominance sort of thing, which is kind of super weird, because I think in the general public we constantly need that. But I just think it's important that we don't apply something to the general public to a very specific athletic body. So then we have the superficial back line. So here is where we would get into the tennis elbow talk. Even at the pro level, you know, while their swing is efficient, they hit a lot of golf balls. A lot of golf balls. Golfers are as ridiculous as you get about over practicing. There's nothing that you can do to change that. I don't even suggest it, because they need to be comfortable with where their game is at. It's kind of my job to make them as good as they can be. All right, and so obviously that immediately draws attention to the extensor group, right? We have an extensor group that is often going to be overworked. It's going to have trigger points. It might be, we'll get strains, etc. And there's only so much we can do on it. Again, that goes back to the thing that, like the pec minor, that how much can you work on something that's just shortened and stressed? And so, well, I think a lot of us do manual therapy on the traps. All right. I think two things. One, with the traps specifically, back to the whole general public aspect of it, we're kind of trained for quite a while to not work the upper traps, and people's upper traps just get tight, right? But when we think about traps, right, we mentioned that the traps have to be able to function, okay? And we can't just have this pure rhomboid dominance. We need some upper trap and some middle trap for an anterior or superior rotation of the scapula. And so when we talk about taking pressure off the extensor group, then that could kind of show how that's even more important, that they need to function and not just be constantly getting stressed. Because even if someone's traps are tight, because maybe they just simply carry their stress there, if we don't do any activation drills, they're just in this position here, maybe due to faulty breathing mechanics, how they sit on a plane, etc. That doesn't necessarily mean that that trap is functioning well. And if it doesn't function well, now you have a superficial back arm line that is putting more stress on its extensor group, because traveling up that chain just is loosey-goosey on their swing. And that's kind of the same in my eyes with a deltoid. In the last slide, we were talking about how much manual therapy we see people do on the rotator cuff, but you don't see a lot on the deltoid, right? When we're talking manual therapy, I think it's a completely separate talk about kind of the reasons why you do it. So for this talk, we're just going to generalize it into basically making soft tissue happy, right? Whether you dry needle, whether you do minutes, strumming, pin release, whatever. It's essentially just trying to make it happy. Me personally, because of time and how many players I have, I do a good amount of dry needling. And so I'll needle the deltoid on a somewhat consistent basis for anyone that ever has extensor group issues. Because in my eyes, I want the muscle right up the chain to be able to function as well as it can to take pressure off the extensor group, right? And so we can carry that on. That it's just something to pay attention to, that this line does go to the fingers, right? I think tons of people do not do much work on the fingers. Again, on tour, we have multiple things for recovery, multiple modalities, whether it's compression, mark pros, so like an E-stem for recovery, and that's why I do stress. A lot of my players get hand massages for that exact reason. because that would be the immediately distal to the extensor group, would get into fingers very quickly. Okay, so the rest, and we're gonna have a few videos if I was smart enough to get the YouTube links going. So these are termed the functional lines, and there's gonna be a couple. The ridiculous picture I found here is just because when I look at the functional lines, we're going to be really thinking about one as the gas and one as the brake. And I do this in all sports. Golf is going to be different in which one is the gas, which one is the power developer, and which one is the brake, which one slowing you down, again, stopping as you swing from your arm flying off. Right. So we're going to start with the back functional line. The POS is not an insult to the back functional line. You'll see it on the next sling. I included POS because it is the posterior oblique sling. In the strength and conditioning world, you will see a lot of people refer to it as that. So if you guys do go on after this lecture and do some Googling, posterior oblique sling, and that is the actual title of the next sling, so you don't even have to worry about writing it down as a note. Might be the easiest Google search. Back functional line, you're going to get a million responses just to kind of the generalization of the words there. And so with this, we won't really get into as specifics because the back functional line, again, is probably where I'm getting a little bit, where we're getting more into exercise programming. All right. The number one thing that you can see, and we'll have a picture in a second, is the lat and the glute. And so going to the next slide, this is obviously the golf swing. You can see he's in his backswing. Right when he starts his downswing, you're going to have right glute and contralateral lat activation. So I included a few videos to kind of try to demonstrate, a very basic to an advanced way to do this. Sometimes when I still do it. When we look at exercise, I think some people think like, well, I'm not going to have an athlete do basic. But keep in mind, when we are talking about myofascial slings and we want symmetry and we want activation, start easy. Because if even though when we program, I'm only getting to have my athletes do a few reps due to power, when I'm evaluating, I might have them do 15 because that's going to show which one fatigues first. And if we maybe have a little roadblock in the middle that's stopping function. And so the first one, very simple. A lot of my athletes then will do this as part of their little activation drills before they play. Let's see if this works. I might be in a view mode that does not let this go. Okay. I hit exit. Something bad might happen. Okay, so let's do this. Let's talk through them. All right. And then if we want to go after, we'll figure out how to get this. This will link to YouTube. And we'll go from there. So a prone, one arm, one leg extension, arms at their side, right? They're prone. They're going to lift one arm and the opposite leg off the ground at the same time. So you can imagine, let's say it's the left arm. The left arm is going to go into end range extension, so lat, and then the right glute is going to go into extension, right? The left hip, so glute. Going from there, a kickstand dumbbell row. A kickstand in the programming world means that one foot is flat on the ground, you're standing, one leg is flat, the other leg is basically just the toe down. So you're talking 95% of your weight is on one leg. The toe down is really for balance. And so you're going to be in a kickstand position bent over. So let's say it's on your left glute is going to be very activated, all right? And then you're going to do a dumbbell row from there to make it a lat exercise up top. From there, a lunge with cable row is just going to get a little bit more advanced, all right? But it's the same premise in that if I lunge, I'm obviously going to be working one glute, let's say it's the left glute, then I'm going to row do a row, usually a little superior to inferior due to get more lat versus teres on the opposite arm. And again, guys, if we need to go back and open up these videos after, we can do that. So then we have the front functional line. The same with the wording would be the anterior oblique sling. All right. When we are talking the anterior oblique swing, keep in mind, and you're going to see this on a picture in a second, in many sports, this is a power generator. All right. In many sports, this is a power generator. In golf, it's the brake. Okay. If I'm uppercutting somebody, it's the power. All right. If I'm, what you'll see in a second, if I'm throwing, it could be the power. Okay. I'm going to have an adductor and a pec. Just look at it that way. Adductor and pec. So here we have a right pec, right? We're going through the obliques, which you always rotate when you throw, and then into that lead leg adductor, all right? The big difference in golf, right, again, is that this is the brake. And so what I have with my exercises is just some chest presses, but a side comment really with how I would apply this. And this is how I talked at the very beginning about how when we program, we just make exercises that look like a golf swing. The issue with that is you cannot duplicate the golf swing, really. What we need to be doing is duplicating those muscle groups firing together. And so if we think about it from this angle, let's say you have you're doing a med ball throw against the wall. If you're looking at it from this framework, a med ball throw that let's say is like a one-arm shot put against the wall, all right, so you're gonna hold it with two, but basically twist and rotate off one. You can imagine is a very chest dominant throw. And so then we are getting concentrically explosive with something that has an eccentric, right, roll in the golf swing. If you compare that to let's say like a chopping throw. So you start with the ball high, you're going down at an angle. Because that is going to be then a lat dominant throw. If you compared the two next to each other and immediately looked at a golf swing, depending on the exact angles, a lot of people would then say the chest throw looked more like a golf swing, okay? But keep in mind that your muscle groups will be very different with how they're functioning. A chest throw, we're lengthening the lats, right? It's eccentric to make your arm not fly off. And your pec is doing the work, right? And so, and that again, that's kind of my go-to example of why we don't just try to duplicate swings, all right? So in the exercises, right, we have these are dumbbells. So we have a one-arm press with a bridge with adductor squeeze. So essentially someone would be lying on the floor with a little ball between their knees, and they would go into a bridge. And so that's going to get your adductors turned on a little bit. If we want to make it complicated, we could be on one leg with a band pulling them out so their adductor was on, and then we're going to do a one-arm chest press. From there, we will go to a one-arm, one-leg dumbbell chest press. Usually how that is their shoulders are on a bench, one leg down, one leg is basically just hovering, and then the opposite arm is doing a chest press. Going from that, the third one would be a 45-degree cable chest press. And again, my apologies. I was so proud of myself that I thought I was good here with the whole getting videos linked. A 45-degree cable chest press would be turning your body 45 degrees while pressing. And the reason we do this is just to stress it eccentrically and really try to make it kind of go with the roll that we intend. All right. Okay. So our last line, guys, I know it's almost 7. Trying really hard to get you guys to dinner. The last line would be a lateral line. This is huge for us. Again, One, because golf has a lateral component. A lot of sports do not have a resisted lateral component unless it's kind of unintentional, i.e. A wrestler gets caught, right? And suddenly you have a lateral resisted component, but in golf you do. All right. Some more than others. A lot of players are tall, which then stresses their lateral line even more. So a few things to notice here. One is if we look at the right side, the two things that really stick out if you guys get into competitive golfers is a fibular head and a first and second ribs. The reason those are important, let's start with the ribs. They're traveling a ton. You sleep on a plane, you're super close to getting the first rib to get jacked. All right. They're stressed, which changes your breathing position. If you're sympathetically driven, right, you're getting accessory muscles, your scalings to go on, they might jack up a first rib. And so we are constantly paying attention to first and second ribs. If you've never seen someone with a super jacked up, elevated first rib, be super thankful, because it's not a fun patient to deal with, right? They're going to be super uncomfortable. But why it is so huge in golf is, if you have not seen this, if a first rib goes super high, you cannot rotate to that. You cannot cervically rotate to that side, because essentially the first rib is so high that the transverse process, C7, as it turns, bumps into the rib. Because of the swing, we often have a little bit of elevation on the right first rib. If you can imagine the finish of a golf swing, you're in right cervical rotation. If that first rib gets too high, they cannot finish their golf swing. It's not even a pain thing. It is simply they physically cannot finish it, which is why we're always keeping an eye on ribs. And then the other bony landmark that I mentioned is a fibular head. The reason for that is going back to almost the beginning of the slide, how I mentioned that the left, the lead foot, usually the left foot, is going to be usually good at dorsiflexion and rotation, while the trail foot is often going to be stuck in plantar flexion and not overly mobile, right? Obviously, dorsiflexion, plantar flexion, we mess with fibular position. The other aspect that you have to factor in with golf is that these players, when they're reading a putt, right, when they're seeing how they should putt, are in a full squat, right? A lot of them are going to get their heels up, but essentially you are in absolute full knee flexion. If your fibular head, when you go into knee flexion, we need the fibular head to anteriorly translate. If your fibular head position is off, we're going to start having issues with that. They're going to either have pain when they deep squat, or we may eventually get more tibial movement and get set up for like a meniscal tear. Okay, so we are constantly in this little battle of getting fibular head position and movement as optimal as it can, versus what the golf swing is constantly making it do. And so then when we look on the left, we start with peroneals, right? And it immediately goes to the anterior ligament of the fibular head. And so it goes back to lead leg. Peroneals are trying really hard. If they get overly stressed and tightened in trigger points, they are going to immediately start pulling on that fibular head, all right? And same with glute max, right? If glute max and then TFL, which we have already talked about, have an issue, fibular head is going to have an issue. And so in the lateral line, the interesting thing, in my opinion, is the lateral line is we have stuff that they're lateral, but they cross the midline. And so normally, right, we look at glute max and TFL as complete opposites, but in this case, they're together, and we need to make sure that they're evenly together. And so going back to what we kind of discussed before, in that if you're doing a lot of manual therapy on the glute max and your manual is good, so you're affecting it, but not doing TFL therapy, you are now creating kind of an uneven pull. In that case, which then could mess with fibular head position since it's right down. And we can even take that super high, if we wanted to look at super high up, it's the same situation. SCM and splenius capitis, they, even though they're both lateral muscles, remember that on the same side, they rotate differently. SCM is a contralateral rotator, so my right SCM rotates me left, but splenius capitis is a same side rotator. In a sport that is causing an insane amount of cervical rotation, and depending on someone's swing, often way more to one side, we are going to have uneven cervical rotation range of motions. And so if we look at it from this lens of we need the splenius capitis and the SCM to both be working and fairly evenly, that might then direct our manual therapy to make, let's say, the right SCM super happy, because we don't want it to lose to the right splenius capitis. All right. My last time apologizing, because we'll have to figure out how to load these exercises. Also, this is easier to explain, I think, maybe. For anyone that's not familiar, a Copenhagen is a type of plank. And so a Copenhagen plank, essentially, if you think about like an abductor plank, would be, let's say you're on a side plank, your top leg will be off the ground and just hovering. So in the abductor plank, your bottom leg abductors are doing all the work. On the flip side, a Copenhagen adduction plank, if you imagine you're doing a side plank, your top leg is on a bench, and then your bottom leg would just be hovering off the ground, slightly right below the bench. And so all the work is being done by that top leg adductor. All right. And so when we do lateral line things, the lateral line outside of golf would be a big postural thing, right? And so there's actually research that if your Copenhagen planks are very asymmetrical, you have a higher incidence of back pain, right? In our world, especially in female golf, again, more than men's golf, we have a strong concern of hip instability. And so we want those force couples of our abductors and our adductors to be as even as possible, right? And so even though we have a sport where the abductors are being super stressed, so as you can see in the swing, you can see that, you know, when we say stressed abductors, we're really saying that our abductors are controlling that adduction on the lead leg, on that left leg, which you can see there. But at the same time, our adductors have such a strong role in especially pubic stability that we want them to be super even. If this left adductor gets super strong because it's working so hard and then starts dominating the left adductor, we could run into trouble. I'm going to go back one slide because this is possibly my favorite example of this. The other thing you'll see with lateral line stuff is if you look on the bony side, right? It's basically just hip in that middle there, right? Like hip, hip, hip. I don't know why we list them separately and don't just write hip. The lead leg of a golfer, right, is going into a extreme internal rotation. And so it is the incidence of hip labral issues in a professional golfer are not super high, but they exist. You know, in a perfect world, someone gets a little irritated and we get it worked out before it becomes a hip labral issue. You can imagine golfers don't let me lock up anything. Their swing is their swing. For people used to ankle taping, no professional golfer will ever let you do a traditional ankle taping job. They'll say, I can't feel the ground, I can't move how I want. They won't let you do it. We lock up. We do like a calcaneal lock with kinesio tape that hardly does anything. And so you can imagine if someone has a hip issue, we really can't lock up their hip. One, it's super hard to tape a hip. Two, they have to move through a crazy range of motion on their lead hip. And so what we do, and I'm not even kidding on this, we have multiple professional golfers right now that, due to hip labral involvement, either current or just past injury that now they want to keep happy, we tape to help their perineals, basically. So we do a taping job to resist inversion, right, and assist their perineals, and that alone will help their hip pain. All right, and so that I think I want to close with that because I think it is my favorite example of the interconnectedness of this, and really how on a almost daily level I directly found a treatment for a more proximal issue by looking distally. All right, guys, a little after 7, and so I'm kind of glad videos didn't work because it would have taken even longer. And so questions. I think Dr. Henny's going to take it from here in a second. That's my Instagram. Evil Betty's my dog, and that's my email. When I share it, I kind of love talking shop. And so when I say don't hesitate with questions, I really mean it. You know, I kind of like talking with people almost daily, and I'm pretty good at getting back to people with golf questions. Dr. Henny, you have, I don't know, I can't see if people ask questions during or where we're going now.
Yeah, let me go ahead and get this signed up. Okay, so there were a couple of questions as they pertain to the slides. They were there, and I'm not sure if you and Ann had that discussion previously, but regarding whether or not the slides might be available. Is that something?
Yeah, it's completely up to you. They're yours now.
Okay.
I wrote that for you.
And so that question came from Christine, and then Nadine was curious if you had any particular handouts or any, you had mentioned one particular book that if folks wanted to do a little bit more of a directed follow-up that you might suggest.
Yeah, so Anatomy Trends, the book, and they have video courses as well. I full disclosure, I haven't watched their video courses. But Anatomy Trends book would be my reference for this. I will, when I'm on the road, or if I'm looking for new exercises, I might just Google it. But Anatomy Trends at this point, I think, is still the most comprehensive resource, and it is for both. I would say it's for both exercise-based people and manually based people. And so the book will have basically a deep dive into the anatomy and the interconnectedness of it, and then a separate section on the manual therapy base. And so if you don't do a lot of manual in your setting, you could actually read just the sections of the book that apply to you.
Okay, awesome. And that will, so if we send those out, then they will be able to go through and click through the videos.
Yes.
I'll give them another minute or two if they have any particular questions. Good. Well, certainly everyone has the contact information. You're welcome to reach out to us, but you can reach out to our fantastic speaker who did a very good presentation tonight. Thank you very much for that.
Was I looking moderately at the camera?
Absolutely, yes.
Okay.
Yeah, showing us, this is the location, Pathfinder, look here. So that, indeed, you stayed well positioned. And no dogs barking in the background, so all good. Nadine was asking, the YouTube videos were the descriptions that Dr. Alex Herzlin was going through, which were predominantly sounded like exercises, strengthening, and mobility.
Yes.
And the book was the one that was referenced at the beginning, and that is Anatomy Trains.
Yes.
Trains. Okay.
And I even included the picture of the book just in case people did want to reference it. That's always easiest when I'm on Amazon, so I know what the book looks like.
Perfect. All right. So that should, Nadine had a couple extra follow-up questions about that. So we should be good to go there. Well, thank you very much for your time, and thank you for everyone who came. We had a lot of people, so hopefully this was something that was beneficial for everyone, and hope you guys all have a great night.
All right. Thank you.